Hello, everyone. Welcome to the last lecture in 1319, which is chapter 9 in Loosening the Grip. Has to do with evaluation and treatment. And that's what we're going to do this afternoon. And as you probably noticed, this was kind of a lengthy chapter compared to some that we've looked at, but had a lot of good information in it. And I'm going to go over some of that with you now as soon as I share my screen with you and we take off over to the PowerPoint. Whew. I'm getting a little tired on my end of it. How about you guys? Anyway, there you go. Chapter 13, chapter 9, and loosening the grip. So what is treatment of a substance use disorder? There are plenty of different methods of treating SUDs out there. You've got, and some things that aren't really considered treatment, like support groups, 12-step groups, Palmer Drug Abuse Program, Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, etc., and so forth. And they're not per se treatment, but on the other hand, yes, they are, because they're a program of recovery. What separates them from a professional treatment program from a clinical program is diagnosis and treatment methods and things like that. As you know, AA practices self-diagnosis. You're an alcoholic when you say you are. You're not when you say you're not. It's that simple. But there's lots of different avenues. There's medical-assisted treatment, MAT. There's, the brief detox, where you basically get you basically get all of your blood taken out, cleaned up, and put back inside you. There's lots of different things that you can do to find that exit to recovery. Narcotics Anonymous, Alcoholics Anonymous, outpatient therapy, inpatient therapy, partial hospitalization, medical assisted treatment, opioid replacement therapy. So it's not a one-size-fits-all approach. If you go to a 12-step program, they basically adopt a dichotomous diagnosis. You either are alcoholic or an addict, or you're not alcoholic or an addict. But in reality, out here in the real world, all alcohol and drug problems are not indicative of emerging addiction. If the first time that you ever use Xanax, for instance, you overdose, wind up in a hospital, and in a life-threatening situation, that's a problem. That doesn't make you an addict, but it does mean you have a problem. If you get arrested for a DWI, that doesn't mean you're an addict, but you do have a problem. And we can help with these types of problems, whether a person's an addict or not. Effective and appropriate treatment, though, really begins and is tied to the degree of severity that a person's experiencing. Not everybody who walks through the door needs to go immediately into detox and then enter a 30, 60, 90-day hospital program. Some won't need detox at all. Some don't need to go inpatient anywhere. They'll do just fine in an outpatient setting. And many of them will do just fine if we send them to a 12-step program without any treatment at all. Some will respond very well to a brief intervention that we do in our office that day, and then maybe refer out, or maybe have them come back for 2 or 3 more short visits, and they'll respond very well to that. So it all starts really with an appropriate assessment to know what it is that we're looking at. Alcohol problems are not restricted then for those who meet the diagnostic criteria. And when we give someone an evaluation or we use a screening instrument on them, like the audit or the SASE or the Mortimer Filkins or whatever we're using, uh, they may fall well under the bar of of needing treatment. But if that's the case, just by doing this assessment with them, it puts us in a position where we can be useful in as much as we can reinforce the good choices that they're making and point out to them where they might be having some issues. If there's something else that brings them to us, and indeed sometimes there is something else that brings them to us, our evaluation assessment should help us to recognize that there's something else going on that is not within our scope of practice, and then we can make referral from that point. If we have to have a diagnosis of dependence in order to provide service, then many who want and who need our help may go without it, and we don't want that to happen. Adolescents present unique problems. They're a different population to work with because their brains are not developed yet. Adolescents can reach in a matter of months the same type of addiction severity that it may take an adult years to get to. Adolescents may not have a particularly problematic pattern of use, but because of their ages, they're doing something that's a crime for them, but it's not for an adult. So a lot of times we see adolescents coming to us because they're in trouble with the system. Any drinker can have issues. Mommy's got her buzz and role responsibility, and they don't jive. She's got a new baby on her hands, and she's stressed out. She might want to relax a little bit with booze now and then, but babies require a lot of attention. That could lead to problems. Anytime a person uses anything, anywhere, there's a possibility, not necessarily a likelihood, that things can go south on us. We get in trouble. We're in the wrong place at the wrong time. Get arrested at a party where there's controlled substances, even if we're not using them. That's the first time I went to jail, by the way, that I'm describing. I didn't run. I hadn't done anything. Everybody else was split, and cops got there and arrested me because I was standing there. But anyway, that's another story. Sad one, though. We look at, when we talk about substance use being an illness in America today, we're looking at the chronic disease framework. And chronic disease framework doesn't fit every situation that we find. The best treatment for a substance use disorder now and forever is don't get it. If you don't get the illness, then hunky-dory. You may have all of the factors, all the risk factors that are there to set you up for bad things happening if you get it. But if you don't drink, you won't get it. Don't use, you won't get it. If we can prevent it, ounce of prevention is worth a pound of cure. Poor Richard's Almanac. I'm not sure that Franklin came up with that himself, though. Risk factors are recognizable. And that's true, and we've talked about that on and off all semester long, right? If your mom's an alcoholic and your dad's an alcoholic and all your brothers and sisters are alcoholic and your aunts and uncles have problem drinking and are drug addicts and have schizophrenia and bipolarity and stuff like that, it doesn't really bode well for you if you engage in this type of behavior. Prevention methods exist, and we have all kinds of prevention that's going on out there. We've got prevention that's, for instance, universal prevention, where you provide information to anyone. Eighth graders, you have a prevention program for eighth graders. That's universal. It's everyone in the eighth grade gets to participate in this. Then you have indicated prevention. And that's for people who have risk factors or, who we suspect they may have been dabbling, or maybe they have been dabbling. We have tertiary prevention for people who have been using or have been engaging in a behavior, and now they've had an intervention done of some type, uh, participated in a program, got some kind of treatment, and now they're not using. But we want to make sure that they stay that way, and that's where relapse prevention as a tertiary approach comes in. The time when it's most critical to act is before an emerging problem is firmly established. But we don't always recognize when that problem is being established. We don't even see it really as emerging. So that sneaks up on people sometimes. And we've talked about that over the course of the semester as well. Uh, so what we're doing when we're looking to provide early interventions and things like that is raising the bottom. And if you'll remember Jelinek's curve, and you came down from this pre-alcoholic stage through the prodromal and then the chronic phase and then into the crucial phase, the I said that backwards, didn't I? It's the crucial phase and then the chronic phase. I'm sorry. Uh, I just heard myself after about a 15-second lapse. Anyway, uh, into the chronic phase, that you're at this bottom. And as we also talked about before, uh, not everybody gets up off the bottom. The bottom can be fatal for a lot of people. This is as far down as you go when you don't come up again. Uh, but if we raise this bottom to where we're intervening up in here, our curve's not nearly as deep. You see what I'm saying? Uh, and so raise the bottom, and fewer people will die from hitting it, which is what we want to accomplish, right? In a modern approach, and unlike it was in Bill Wilson's day, it was no longer assumed that a person with some sort of drinking problem automatically falls into a chronic disease stage of progression, because they may not. We have people who exist all up in here and don't get any worse, but that doesn't mean that they don't experience some type of problem, even if we can't diagnose them as chemically dependent. Clinical implications within a chronic disease framework, responsibility for care doesn't fall but directly and solely on people like you and I. It's not something that it's something that comes to the substance abuse treatment community, that comes to the substance abuse recovering community, but it goes through stages before it gets there. I mean, if I look at my own use, you think my teachers who saw me stagger into class and pass out at my desk, you think they knew something was wrong? The policeman who locked me up and kept me overnight and then let me go and said, "See you next weekend." Do you think he thought could have figured out something was wrong? Truth of the matter is that people with emerging substance use disorders, if we're looking at that chronic disease framework, we're going to continue what we're doing, and we're going to get worse as time goes on. But there are all kinds of places for interventions to take place in there. And by interventions, I don't mean the thing that you see on television on that show. That is an intervention. That is not the intervention. There are plenty of other types. It can be something as simple as a doctor here talking to this young lady and saying, wow, this is the third time you've been in here in 2 years, and all three times it was related to prescription pills, you know, and then start with that intervention right there. Do you think you may have a problem? Is there something you'd like to do about it? I know some people you can talk to. That's an intervention. We have alcohol use disorder identification tests that for years now, the treatment community, and I was involved in an epidemiological study for that, was trying to get people in emergency rooms to use these audits as a 10-question screening instrument that people can answer, and it's got a numerical score associated with it. And we tell the people what the numerical score means. This whole process takes 15 minutes, maybe. But it can identify where there may be some problems, and you can query whether people want to do something about it, and if so, have some resources ready for them. It doesn't have to be a trained counselor doing this. A nurse can do it. First responders can do it. Policemen can do it. Emergency room personnel, physicians, dentists, lifeguards, people can do this type of thing with someone who's just had an incident with alcohol or drug use, and maybe refer them into to either an educational place or to a place where they can receive some treatment. These types of early interventions do not require diagnosis, but they can still have a profound effect on behavior. When we talk to people about what they're doing and how they're using and things like that, based on something that we may get from an audit or, from an ASI or some other, some other screening instrument, then the good choices that they're making, we can tell them about it. This is great. You're doing wonderful. You need to keep this up. This is, you're making good choices. They can be reinforced. And problem areas can be addressed. When you drink, you can't remember what happened when you're sober, when you've been drinking. That's an abnormal reaction to alcohol. That might be a red flag, and there's someone you can talk. I know someone you can talk to if you'd like to, that sort of thing. Screening efforts for substance use disorders and other disorders, along with lab tests, can be administered at this time as well. We don't do a lot of lab test diagnoses for, as a diagnosis method with substance use disorder clients very often. But there are other tests that can be done, if we suspect something else is going on with them. Administration of the audit and the subsequent brief discussion is not treatment, not really. Although even this brief encounter can bring about some rather profound changes in a subject's life, and we've had research to determine that. And this is coming from Howard Bushart, by the way, one of the biggest scoffers at brief intervention. When I first ran into it, I'm like, oh, hell. I just tell them, sure, whatever, and go on and do my thing. And I was very disparaging in both my thoughts and approach to brief interventions. And I was absolutely wrong. Brief interventions work very well. And I recommend them, for everybody all the time, continue to do the brief interventions. Oddly enough, even in the age of the internet and disinformation and anti-social media, we still listen to each other. That's weird, isn't it? Anyway, screening instruments. Let's see if I can show you one here. And I hope I can do this without squirreling up my, what's that saying? Okay, I know that. This is your basic audit. It's very short, doesn't take long, has 10 questions. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you're drinking? How often do you have 6 or more drinks on one occasion? How often during the last year have you found that you were not able to stop drinking once you'd started? That's a key question, by the way, loss of control, right? You knew that. I knew you did. How often during the last year have you failed to do what was normally expected from you, that should be of you, because of drinking? Uh, how often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking episode? Or to avoid cutting your throat while you're trying to shave, or all of this stuff. How often during the last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been unable to remember what happened the night before because you'd been drinking? Have you or someone else been injured as a result of your drinking? And has a relative or friend or doctor ever said anything about it? And here's your scoring guide. Now, this PowerPoint, of course, is going to be posted in your classroom. Uh, it may already be there. I don't remember. But so you can go to this link and look at it at your leisure, print them out, give them to your friends, practice on your kids with them, whatever you want to do. But this has got a numerical score associated with it. Most of these instruments do. And based on your numerical score, and this is the type of drink that you have. Uh, if people want to know, well, what's a drink? And based on your numerical score, you fall into a category. And that category uh, indicates whether you do or do not have a problem, what kind of problem it may be, etc., and so forth. There you are. I lost you for a minute, but we're back. Cage is a short instrument that you can you can ask people questions and fit them into categories. And the CAGE is cut down on your drinking. Have you ever felt you should cut down on your drinking? That's the C. Have people annoyed you by criticizing your drinking? That's the A. Have you ever felt bad or guilty about your drinking? That's the G. And have you ever had an eye opener first thing in the morning to steady nerves or for a hangover? And you may have noticed already that there's this eye opener thing seems to be a common theme in these tests, and it is because that's the drink that we take in the morning to stave off withdrawal syndrome, shakes, and all that kind of bad stuff that comes along with this. Uh, and you'll also note that many of them have the same questions about what about excuse me, loss of control. Do you often drink more than you intended to drink, or do you have trouble stopping once you start? Makes sense. This is a one that may be recognizable to you guys because it's been around a long time. And one of the reasons it's been around a long time is because it's a very good screening instrument. It's called the Michigan Alcoholism Screening Test, or MAST. It's one of the most widely recognized of the screening instruments. People have taken it before because sometimes they showed up in magazines such as Psychology Today and Cosmopolitan and TV Guide, and some of you older people probably remember TV Guide magazine, etc. And they would show up, and they still show up online and things like that under "Do you have a drinking problem? Take this simple quiz." And you take that simple quiz. And there are variations of the MAST: the brief MAST, the short MAST, the mini MAST, the geriatric MAST, or the MAST G. And all of them have, basically the same intent, which is some of them have 10 questions, some have 11, some have 13, some have 25. But all of these are numerically scored. And the reason this test has been around, like I said, for a long time is it's quite an accurate test. And if you take one and you answer honestly and look at your score, pay attention to that score. Do that with the audit too. If you take any of these tests, and I'm not trying to do an early intervention on any of you, except I kind of am, yeah. But pay attention to this score, because this score will tell you something. Now, I took the MAST. I took it again last night. Yes, last night, for purposes of putting together this presentation. And one of the things I discovered is if I answered honestly, I didn't get past 5 questions before I was in trouble. So, without further ado, if you got a pen and paper with you, and you want to do this, or if you want to wait till later and look at it on, the PowerPoint, that's fine. But go through these questions, and you can go through them with me now. Do you feel you are a normal drinker? No is 2 points. And honestly, no, I didn't feel like I was a normal drinker. I didn't feel like I was normal at all, especially when people started remarking about it at the age of 17, 18. Why do you drink so much? Have you ever wakened in the morning after some drinking the night before and found that you could not remember part of the evening before? Well, yeah. Okay, 2 more points. Whoop. Does your spouse or parents ever worry or complain about your drinking? Yeah. My spouse and my parents and my relatives and my friends and my teachers and my, everybody, Can you stop drinking without a struggle after 1 or 2 drinks? No. I'd rather not have 1 or 2 drinks if I had to quit after 1 or 2 drinks. I'd rather not even start. But it takes considerable effort on my part not to continue drinking after a couple of drinks. Do you ever feel bad about your drinking? Yeah, I do. Yeah, I've always felt a certain amount of guilt. Not so much for the drinking, but because of the things that happened while I was drinking, or, the consequences of it, whatever. But yeah, I've felt bad about my drinking. Do friends or relatives think you're a normal drinker? No. When people that I always thought were kind of rum heads are telling me, man, you need to slow down. Uh, uh, do you always start drinking this early in the day? What's wrong with you? They don't think I'm a normal drinker. And I've got relatives now, if I walk out the door and get struck by lightning, they're going to say if that SOB hadn't been drunk, it wouldn't have happened. But anyway, so no. That's 2 points. Do you ever try to limit your drinking to certain times of day or certain places? Yeah, unsuccessfully, but yeah, I've tried that. I've decided I'm not going to drink before 5 o'clock, but then it'll rain and the job's called off and it's 10 in the morning and we go to the bar anyway. Yeah. Are you always able to stop drinking when you want to? No. Plenty of times I've stopped just to have a beer with a friend or a co-worker or something and wind up, getting poured out the door at closing time. Have you ever attended a meeting of Alcoholics Anonymous? That's 5 points, dear hearts. Yeah, I've attended hundreds of meetings of Alcoholics Anonymous. Have you gotten into fights when drinking? Duh. 1 point. Has drinking ever created problems with you and your spouse? Again, duh. 2 points. Has your spouse or other family member ever gone to anyone for help about your drinking? Yes, they have. 2 points more. Have you ever lost friends or girlfriends or boyfriends because of your drinking? Of course, 2 points. Have you ever gotten into trouble at work because of drinking? Yes, 2 points. Have you ever lost a job because of drinking? Yes, 2 points. Have you ever neglected your obligations, your family, your work for 2 or more days in a row because you were drinking? Absolutely. 2 points more. Do you ever drink before noon? If I'm awake, yes. Have you ever been told you have liver trouble? No. Finally, no. you know, no points. I got no points. Have you ever had delirium tremens? Well, no. Severe shaking? Yes. After heavy drinking. Convulsions? Yes. So I guess that's 2 points. Have you ever gone to anyone for help about your drinking? Yes. And that's 5 points. Several times. Didn't believe them, didn't buy what they had to say, but yes. Have you ever been in a hospital because of your drinking? Yes. Uh, it wasn't, I might have said, well, it wasn't because I was drinking. It was because I got in a car wreck or because, whatever. But yeah, it was because I was drinking. 5 more points. Have you ever been a patient in a psychiatric hospital or on a psychiatric ward, etc., so forth? No, I was never diagnosed as an alcoholic through any of that. Uh, no points. Eureka. Have you ever been seen at a psychiatric or mental health clinic or gone to a doctor, social worker, or clergyman for help with an emotional problem in which drinking has played a part? No. No points. Boy, I tell you what, I feel like breaking into a happy dance. I had two no points in a row. Have you ever been arrested, even for a few hours, because of drunk behavior? Yes. Have you ever been arrested for drunk driving or driving after drinking? 2 points. Yes. And then look at here. A score of 5 or more points indicates alcohol dependence. 4 points is suggestive of alcohol dependence. I had 4 points after the first 2 questions and a score of 5 after 3 questions. I didn't even have to go through the other 22 to get there. And there's my score. A score of 5 or more points indicate alcohol dependence. Howard's score 49. But here's some other tests that you can look at. I'm jumping forward a couple of slides because it occurs to me I didn't put these entirely in the order I wanted them in. Screening instruments are very reliable, but they're not foolproof. Clinical judgment is still required. Counseling skill is still required. And the reason for that is, you'll recall, I think it's question number 9. Yes, it's question number 9. Have you ever been to an AA meeting? If I'm just writing this down, if I'm filling out a form before I come into your office to talk to you, you look at that and go, oh, here comes Howard. He's already in the alcoholic range. But when you talk to me, I may tell you about that AA meeting thing. That my dad got a DWI back when I was in my early 20s, and I was living at home because I was separated from my wife, and I was staying with my dad, and he had to go to meetings, and he didn't have his license was suspended, so I drove him to AA meetings, and I made a few of those AA meetings with him. I went in there and kept him company while he went to them. Does that count? Does that mean that I should consider that AA meeting attendance a sign of my nascent alcoholism or whatever? But you get my drift. And sometimes, you want to talk to the client and you can draw out more information. It's what's called fleshing out a flash, if you remember your theories class. You got a clue that something's going on here. You want to find out more about it. You want to verify a hunch that you have. I'm sorry, I've got the hiccups now. I'll try to work through this with you. But that sort of thing. Other type things. We've done the mass. There's the alcohol use disorder screening test, or the audit. I showed you that. There's the TWEAK, an acronym for tolerance, worry, eye opener, amnesia, and K, because C doesn't work there, for cut down. And it wouldn't say TWEAK properly if you used a C. Just saying. the audit, 10 questions, categories, suggested interventions, etc. A craft for adolescents, ASI, alcoholism severity index. There's web-based stuff. There's the Columbus, and I can't recall the other one right now. But there's a number of those too that you can do online. This is the DSM-5 diagnostic worksheet, and this is pretty handy too because it's moving towards diagnosis. And if you're using this, you put, Joe Blow up here, and possible symptoms. Not a typical social drinker. Drinks more than they intended. When out, their plans are easily modified. They're only going to drink a couple of drinks here and then they're going to go home, but they run into an old friend, says, let's go partying and dancing over here at this club, and away we go, etc. Along the way and during the night, our client has a few more drinks than others. He has greater quantity in the past, has a habit of drinking more than the people around him, and maybe some other things. And the diagnostic criteria from DSM-5 is that the individual's drinking more or longer periods than intended. And it runs down through the diagnostic criteria, possible symptoms or indicants of that diagnostic criteria, and over here, yes or no. And when you reach the end of that, you've got your total yes. And for a total yes, if you got 0 to 1, then you don't have a problem. 2 to 3, then you have, a mild case of substance use disorder. 4 to 5, moderate, and 6 or more is severe. What did I do right? That's 61 there. That's incorrect. It's a 6. Just saying. I don't know why I did a 1. And then there's physiological dependence, which is indicated by withdrawals. Again, reliable but not foolproof. And even when we have the most reliable screening instrument, the thing that really defines what we do and that makes a difference in the client's life and in our lives as well is relationship and interaction. Very important. Brief interventions consistently have been shown to reduce drinking as well as alter risky drinking patterns when utilized with people. If we sit down and you are truly concerned with what's going on in your life, and particularly your use, and we talk about it, and I can level with you, and you can level with me, it's transformative. And like I said earlier, people do, in the final analysis, when we interact with one another, we tend to listen to one another and take, even truths that I don't want to hear and truths that I don't want to believe, I will take out with me. Brief interventions are equally effective when utilized for prescription drug use, oddly enough. Screening and brief intervention to referral and treatment, or SBIRT, is a kind of a modified version of motivational interviewing that's commonly coupled with the audit screening instrument. You can give the audit and do an SBIRT in 15, 20 minutes, And these methods lend themselves well to prevention, to education, to harm reduction, and to screening and referral, which is where probably their most beneficial uses are in the screening and referral areas right now. Some common elements of brief intervention is the frames model, and that's where you give feedback about the client's personal risk. And if you personalize risk to someone, this personal, that's the name says it all. If you are talking in general terms out there about, you should wear a mask and you should have 6 foot distance, and you should observe, hand washing, social distancing, mask wearing, all that stuff to prevent COVID-19. Uh, and I'm running around thinking, yeah, well, I probably won't get it, and if I do, I'll probably be okay. But then someone sits down and says, no, listen, H, you're getting on up there, dude. And you were a smoker for many, many years. Your lungs are older than the rest of you. you know, uh, you're overweight. You have all kinds of things that are risk factors for someone who gets COVID-19. It could be very well be fatal to you, and you could take it home and infect other family members and make them sick too. Now it's getting personal. Now I'm seeing not just the health risk to me, but to other people too. That kind of feedback is helpful because it helps me make informed decisions, and it helps me to see, what I'm doing and how it's affecting me and how it's affecting other people as well. It also brings me to the R part of brief intervention, which is responsibility of the patient. It when I know something, it's I have a responsibility. If I want change to occur, I have a responsibility to do certain things. You know, I can sit around and take all of those mass tests where I score 49 all day long and sit there with, and consume beer after beer and smoke joint after joint and pop pill after pill all damn day long, and never get up and do anything about it. Knowledge is not, in and of itself, going to bring about any change in me. It's knowledge tied to behavior that's going to bring about changes and is going to bring about recovery. Advice to change is good, although I like to reinforce the client's advice to themselves. I need to do something. I can't go on like this. I really need. I'd save money if I quit smoking. And I'd set a good example for my children, and I wouldn't burn my clothes up. My house wouldn't stink. There's a whole bunch of good reasons that I would advise me to stop smoking. And my counselor can get me to advise myself. And if he can't, he can say, "Hey, do you mind if I make a suggestion? Maybe you ought to consider doing this." Menu of ways to reduce drinking. What can you do? What do you want to do? What are you willing to do? How would you like things to be? What do you see as a method of getting there? How would this be helpful to you? Menu. Well, I can not drink during the week. I could come straight home from work. I could ride with my brother who's a teetotaler and he won't stop at a bar. This kind of thing. There's all kinds of things we can come up with. Empathic counseling style. Empathy is to experience the client's reality as if it were your own. You suspend your judgment and you listen carefully and you listen with an attempt to place yourself in the client's reality, to understand things from their point of view, without getting lost in it, of course. So when you do that, and you can make statements back to the client like reflection of feelings. Wow, that sounds terrible. You must really be frustrated with this situation, and maybe hurt too. That kind of thing. And you have to be right most of the time, not all of the time. If you're wrong all of the time, people aren't going to want to talk to you, But you have to be right most of the time, and you have to listen and empathize, and then give it back to them in terms of feedback. Then self-efficacy. Tell people about what you see about them, their strengths, how they're managing things, and be optimistic for them. So you've got this going on for you. I think that, this, and you don't have to stretch things. You don't have to lie or anything like that. It's not like that, what's that commercial in Pinocchio? I see Winter in all of you. Why he couldn't be a motivational speaker. But anyway, I digress. Self-efficacy or optimism of the patient is a good thing to have and a better thing to share with them. When your screening is positive, when you do find that there's a cause or reason to come up with a SUD diagnosis, alcohol use disorder or whatever, then you need to share those results with the clients. Motivational interviewing is a good way to do that because it's a non-threatening, non-judgmental, relatively easy conversational way of sharing information with the client and evoking feedback from them about how they're hearing it, how they're taking the information that you're giving them. So you share the results. And then when you can, you gather information for evaluation and for treatment. And you have to have an evaluation before you can come up with a good treatment plan. You have to know the severity of what's going on and all of that good stuff. You need to identify situations such as the risk of withdrawal that may require medical attention, or there may be some other type of issues that would require medical attention. People who have seizure disorders, people who have some other type of chronic condition that's underlying their substance use disorder. If they're using other drugs, it may be you have to do a referral, reevaluate, redo your treatment plan, or focus your treatment plan in that area. If there are observable symptoms, if someone is yellow in their eyes, if someone is not oriented times 3. Also observable symptoms is how how they appear to you, what their affect is. Are they coming across having a normal emotional range? Are they well groomed? Are they bruised up? Do they have tracks? Check things out with them. And this is another indication of what we should do and how we should approach them. If they're oriented times 3, do they know who they are, where they are, and why they are? Do they know why we're here, who I am, when I am, where I am? Those are important questions. If they can't answer those, we probably need to do a fairly quick referral. As far as referrals, every clinician everywhere, every one of us on planet Earth should recognize our practical and professional limitations because we all have them. We all have them. There is no one who can do it all. If a client has issues outside our realm of expertise or outside our scope of practice, we should refer them. And this brings us to some tricky stuff. One, in order to refer, we need resources. We need to have a place to refer to. I have good referrals. If you call me and you need a place to go, I will try to send you somewhere where they can accept you, or else they can do an evaluation and make a referral themselves. Everyone who's in the helping profession should have a list, of referral sites and sources. And here's the thing. We cannot enthusiastically recommend the unfamiliar. There's very few times I refer someone to a place I know nothing about. I either know someone who's there, I've had experiences with them in the past, Or I'm very familiar with the program, like with Alcoholics Anonymous, Narcotics Anonymous, and Palmer Drug Abuse Program. I have no problem uh, referring people to any of those programs that I know because they're a known quantity to me, and I've utilized them before, and I'll probably utilize them again. When you make a referral, there's always a danger of the client falling through the cracks. So that's if if I hand you a brochure and say, here, this is Good Place Treatment Center, give them a call at this number right here and set them up and tell them Howard sent you. Uh, and you say thank you very much, and you walk out the door with that my little pamphlet in your pocket, and I can sit back smugly and say, there, that's all that, until quitting time, and I go out and I find the little handout that I gave you lying in the parking lot, because that's how far you got with it. If I'm going to make a referral for someone, I will say, let's call them right now. Do you want to? I'll give them a holler now, and I'll see if I can get you hooked up with so and so, and I'll be here with you. And if they ask you something that you don't know, I can help you, or whatever. Not only do I not mind doing that, I consider that part of my job. So that when I'm making a referral, I will physically help the client make the call. And if it's someone that I've been working with for a while, actually, it doesn't even have to be someone you've been working with for a while. It could be someone who walks in and sits down, and after a little while with you, they feel so relieved you can see it on them. It's tangible. They finally got someplace, someone's listening to them, etc. And then you turn around and say, here, I'm going to send you to this other place. A referral can feel like rejection. It can feel like, I came in here for help from you, and you let on you were going to help me, and now you're kicking me to the curb. That's the way it can feel. I'm not saying it does to everyone. And I'm not saying it's an intention to make anyone feel that way. I'm just saying that's a possibility. It may even feel like abandonment. Okay, I'm not even worth your time, huh? We have to convey any relevant information regarding the case or client to the referral site whenever possible. I want to get their permission to do that. I want to be able to talk to the person I'm making a referral to if at all possible. I want the client sitting there with me while I talk to them, if at all possible. And when the client talks to them, I will sit right there next to them and hold their hand if necessary, so that they are not feeling that rejection and abandonment. Clinical style in counseling when gathering information. If there's any one thing that I could change about public perception of substance abuse counselors, is that we're tough, and that no one can pull anything over on us, and that we don't take any bullshit. And, we've got that reputation, and it's bogus. I can be had. You can be had. Yes, people can fool me. In fact, they could probably fool me somewhat easier than they can most other people, because I start off willing to believe them. I start off in trust mode. And substance abuse counseling isn't about getting in people's face and breaking them down and tearing down that wall of denial and all of that stuff that you've heard. A good substance abuse counselor is collaborative. We try to meet the client on as equal a basis as we can. We don't talk down to them. We don't insult them. We don't challenge them in the way, or if you're effective at it, you don't. The whole notion of getting in people's faces and the scared straight nonsense is just that. It's nonsense. There is a time for confrontation, but confrontation is not something that you have to throw the client down in your office and stomp their little lungs out. It's not about winning or losing. There are several types of confrontation. One is factual confrontation. This is errors in fact. One of you come in to see me and to tell me about the big old shark you caught down at Lake Houston. He was this big and all that kind of good stuff. Although really he was like that big. And I look at that, I hear what you're saying to me, and I think, why would a shark be in Lake Houston? Why would he be that big? Uh, you know, I guess there could be sharks in fresh water. Bull sharks live there, but it's a rarity to catch a shark out of fresh water, and I'd tell you that. Uh, you know, and if you caught one, it probably wouldn't. Was it really that big? Maybe it's better to go the other way. I caught this. Look at this sunfish I caught down at Galveston Bay. Well, it couldn't because they don't get that big. It couldn't be a sunfish out of a little pond, and they don't live in salt water. They would die if you put them in salt water. So you may have caught something that looked like that, but it's not that. Uh, and when you are doing a factual confrontation, you're just disabusing of clients of errors in fact. You tell them, well, or you're confronting them on, things like, well, sometimes I forget when I drink. Well, you know what? That's retrograde amnesia that you're describing, and it's what Jelinek called an alcoholic palimpsest. It's a current inability to recall something that happened while you're drinking, and what it basically is drug-induced amnesia. Wow, really? Yes, and factual errors. In fact, when you give people information or correct something that you know that they're saying this wrong, it's an error in fact. And you know what's a good idea is to approach that is if they're just making a mistake, not as if they're lying to you, because chances are pretty good they're just making a mistake and they're not really lying to you. If I believe what I'm telling you, I'm not lying. Now, what I'm telling you may not be true, but it's not a lie on my part because I believe it to be true. And I think I'm giving you the factual skinny, right? Does that make sense? And I can be convinced otherwise if you give me some evidence. Experiential. I think of that little dog, Droopy, the Tex Avery character from Looney Tunes, who never changed his face and never changed his expression and never changed his tone of voice, and he will walk into the room and say, "Oh, I'm so excited," or "Oh, now you really made me mad," and then he'd shuffle off again. That's called a flat affect, by the way, that the person's telling you something like, yes, and then, after he robbed me, he stabbed me a couple of times and cut my throat, left me for dead. Like you're reading the evening news, you know. So if you observe that the client's insides don't match their outsides, if they're telling you they're doing fine, but they look like they're on the verge of tears, then there's an experiential confrontation to be had there, and you can do that again in an easier, softer way. You don't have to be harsh or mean or brutal or anything like that. Make sense? A strength confrontation is to point out to people that they're stronger than they think they are, and they are. Man, when someone who is substance use disordered, someone who's been fighting heroin for years, who's been out on the streets, who's been doing stuff, who's been a drunk for 15 years, been put in jail, all this stuff, they're tougher than a boot. They're like that old Timex commercial, takes a licking and keeps on ticking. And people will say things like, "Man, I just feel like everything I touch, falls apart. Nothing's right. I can't do anything right. I can't make it any." You can point out to them some of the obvious stuff. You've made it this far. You're in here. You're in here with me trying to do something about your life. And you're stronger than you think you are because you got here. And now you seem to have a determination to do something different. That's a strength confrontation. A weakness confrontation is when you tell people, you don't have to be strong. You know, everybody has their weak moments. Everyone does. It's okay to be sad. It's okay to be to have grief. It's okay to be confused. It's okay to feel pain, and it's okay to express it. You don't have to be strong all the time. And sometimes all people need is a little permission. And then action, something we can ask to be done. This, dear hearts, is called Around to It. And I looked at a bunch of them online when I selected this image because this looks like mine that I had a box of that I kept on my desk. Except mine, you could turn it over. It said Round to It, and on the back it said Just Do It, DUIT. And I couldn't find that one. Or I'd have showed you both sides of the coin. But there are several variations of it. And I kept this on the desk. And, I had some counselors who were into action confrontations on me. I'd say, they said, "Well, did you do what I told you to do for your last homework assignment?" And I said, "Well, I tried." And then I get responses like, "Trying's dying, brother. You either do it or you don't do it." Or how do you try to go to an AA meeting, Nate? You either go there or you don't. There's no middle ground. You either go there or you don't go there. You either do that thing I ask you to do or you don't do it. So I had a box Around to It, and I'd ask people, have you done this thing? And they would say, well, I meant to, but I didn't get around to it. And that was an opening for me. I'd grab one of my little, it's particle boards, what it was. Particle board Round to It, and flip it to them. And on one side it says Round to It, then on the other side, Just Do It, and tell them there. Now you have a Round to It. Get with the program and get her done. There are 5 basic principles that go into motivational interviewing. Oh, and an action confrontation, by the way, is inviting people to do things. Let me backtrack that. In my action confrontations and the things that I ask people to do, I always put something in there that I know is going to be absolutely achievable by them. If you don't have a job, I may ask you to go home, get a newspaper, although I don't think this is done much anymore. Look at the one ad, see what jobs are out there that might be able to give you an interview. Circle 3 of them and call them this week to see if they might have an interview with you. I'm not asking you to go on an interview. I'm not asking you to report getting a job. Just find 3 places that might hire you or might talk to you about going to work for them, and then call them. That's taking positive steps. That's moving in the direction that we need to go. It's doing something, taking some action to make your life better. Motivational interviewing. There are 5 basic principles to MI, and one's express empathy. And to do that, you have to listen well. You have to put yourself in the client's shoes. You have to unravel the emotional content of the messages as well as the literal content of the messages, their disclosures. And then when you express empathy, express it well. And you do that because you listened well, so you know what it was that they were telling you, and you know what emotional content was there, etc. Develop discrepancies. Help the client to recognize the disconnect. Some of my classes and lectures are kind of running together for me this semester because of the way I've had to rearrange how I teach classes and stuff. So I know I've used this example in another class, but I don't remember which one or in what context. But in a counseling session one time, I had a young woman talking about how her mother and father, had been together for many years, and they were still being intimate with each other, and she knew that because she could hear them in the other room and things like that, and that there were four kids, and then her mother had basically gotten her tubes tied or something, and couldn't have any more kids, but that didn't keep them from practicing, her words. And anyhow, she was she talked about that, and then she got around to saying something about to telling a story about how she helped her father unpack his suitcase one day when he was coming back from a business trip, and she found a box of condoms in there, so she knew that he was still sexually active. And I asked her, if your mother couldn't get pregnant, what does he need condoms for? And the look on her face was, she was shocked. And she said, I had never thought of that to this very moment, and that's, yeah. So there's a discrepancy in reality and in the way we see things. There's discrepancy about what I tell you about me and what you see about me. And so we develop those discrepancies and help point them out. We avoid arguments. There is no reason for us to argue with clients. It's a waste of time trying to get them to buy some idea we have about them, or them trying to get us to buy some, idea we have about them or they have about us or whatever. It sets up a win-lose relationship rather than collaboration. And when we're busy knocking our heads together, we're not collaborating. So avoid arguments if you can, and you can. It takes two to argue. If the client comes in and wants to argue and you want to argue back, then that becomes a bit of a monologue, and it becomes silly even to the client after a while. Roll with resistance. If the client seems to dig his heel in, Miller and Rolnick, took the tack that there really is no such thing, really, as client resistance. It's just that if we frame a discussion into two positions and we assume one of them, the client by default has to assume the other one. So try not to do that. Instead, engage the client and evoke change talk from them and support self-efficacy. Don't stop to argue, I can tell you right now, Bushart, that I don't care what you say, I'm not an alcoholic, and I'm not going to say I'm an alcoholic just to please you. And I'll say something like, I don't even think we're at a place where we need to be talking about that. I know that you got in trouble at work and you got a DWI, and I can help you with that. What do you want to do? How do you want to proceed with this? It's too early for labels. I just want to know a little bit about what happened and what you want to do about it. And it's kind of verbal judo. Judo, by the way, I'm no martial artist by any stretch of the imagination, but if I were, I'd want it to be judo, because you don't smack people around when you do judo. You just move them. It's called the peaceful way. So that if someone throws a punch at you, you just use their energy to move them away from you until they get tired of doing it. Pretty handy dandy thing if you're quick enough and can do it. And support self-efficacy. Support the client's ability, right, and everything else that goes along with being able to make their own choices in their own lives, because they're the experts on them. This is the change model, by the way. And change model was developed along with the motivational interviewing. In every substance use disorder person's life, there's a day when they're just la 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 out there in a pre-contemplation stage. I really like what this drug makes me feel like. I laugh a lot with my friends, and my girlfriend likes it too. And then we have lots of spectacular sex and partying, and everything's groovy. And who wants to change, And I never think about it until I get in trouble. And then someone points it out to me. When this happened to you, this was going on. When that happened to you, that was going on. And now it's being kind of laid out in front of me that maybe what I'm doing is not as innocent as I thought it might be. And I've gotten in trouble, and now it's causing me some unpleasant consequences. I'm having to come here to see a counselor, or they're going to put me in jail. I'm having to come here to see a counselor, or my wife's going to leave me. I'm having to come here to see a counselor, fill in the blanks. Now I have to think about it. And once I think about it, I'm in a state of ambivalence when I'm there. Ambivalence means to be of two minds, to be ambivalent. And I want it and I don't want it. I think so, I think not, so I waffle back and forth. This is a seriously a part of the human condition. I mean, it really is. We second guess ourselves all the time. I make a decision and then I immediately regret it and want to decide something else, that kind of thing. But once I see that there are some options for me out there and I pick one, then I have a bit of determination. And when I first encountered this, it was 4 stages. It was pre-contemplation, contemplation, action, and maintenance. They threw determination in a little bit later. Actually, I'm more comfortable working in the 4-stage idea because you can act your way into right thinking a lot easier than you can think your way into right acting. In other words, if action comes from the contemplation, if you say, well, I will do this, I will see what happens next, I will see how this works out, I guess that can be called a decision, a determination, but I want to see the action. If a person just says, yeah, I'm gonna lose 40 pounds someday, somewhere, somehow, sometime, we can start tomorrow. Could I have another slice of pie, please? I don't know how determined that is. Action is the change. People are going to be ambivalent throughout this. People waffle back and forth, and it's sitting on a fence. It's going to be most comfortable when we make a commitment. It's easy to mistake commitment in here when someone tells you, yeah, you're right, I'm really going to do that. I'm going to change that. I'm going to drop them 40 pounds. I'm going to quit having sex with everybody without protection. I'm going to quit sharing needles with people. I'm going to quit sharing needles at all. I'm going to quit using drugs, for that matter. That may just be enthusiasm. That may not be determination. Determination is followed by action. And action is followed by maintenance. And if action is not followed by maintenance, you may find yourself, in a relapse situation. So, we'll be addressing ambivalence all the way through. And part of what we'll be doing, and why this is motivational interviewing that you're doing, is you're going to be motivating people into healthier choices. You're going to be could just as easily be called manipulative interviewing because all the while you're doing this non-judgmental thing that you're doing with them, you're still moving them in the direction of positive, healthy choices. In the initial interview, when you're talking to someone, the interview is intended to get a general picture. And that picture should be something that the client is developing for you right there in front of you while you're talking to one another. what is the problem as the client sees it. You know, it's really dreadful when to go to a counselor who asks you what's going on, and while you're telling them, they tell you, no, that's not it. You know, this is what's happening with you. Then why did you ask me? You know, what is the problem as the client sees it? Does the client have to be right? Oh, right, you're not here with me, are you? No, the client doesn't have to be right. I want to know what's the problem as the client sees it, because it gives me insight into the client's world as they experience it. They don't have to be right. I still want to know, what does the client want? It may be attainable, it may not be attainable, but I still want to know, what is it that you want? Why now? What happened that you know, you're here at this particular time? I want to get some information on that. What's your current living situation? I want to know that. Is there a medical or psychological emergency? And if there is, that's probably going to jump right to the top of the list of things we need to address this morning. And what are the recommendations at the end of the interview? Do not let the interview end without adopting a definite plan for the next step. There should always be a next step. If I talk to someone and I don't find that they have a drug and alcohol problem, my next step might be, I want to give you some information about you know, drug use and possible consequences. Or if I uncover another problem that we've you know, sexual abuse, something like that, I will definitely be helping them make a next step plan for where to go next and what to do next. If this client is going to be under my care, if they're going to be someone that I'm providing treatment to, if they're coming into my program or whatever, I want to agree on something the client can do between now and whatever comes next. Remember that call 3 companies that might give you a job, and you know, something that they can do. And if they're not going to be coming back to see me, if they need to move on, I'm going to help with the referral. You know, and if I don't make a referral and they're going to come back, then we'll set another time and again have something for them to do. Treatment planning and treatment setting, you know, emerges from a thorough evaluation. And that thorough evaluation leads to comprehensive and effective treatment planning, where we're covering all the bases that we can cover. One wants to avoid over-treatment, and we want to avoid under-treatment. And we also want to avoid any kind of unnecessary disruptions to the client's life. Like putting them in a hospital, telling them to quit their job, you know, which, by the way, were both recommendations for me early on. And move out of my house with my wife and kid and move in with a bunch of sober people, which I did. I don't think it's my best choice, but I did it. 6 dimensions of placement. When you're doing your evaluation, you need to be paying attention to these dimensions, because they're going to be informing you what type of treatment you need to put people into or recommend for them, etc. One, the first one is acute intoxication withdrawal syndrome, or likelihood of that. If you've got someone who's withdrawing, the likelihood that they're going to get through that withdrawal on their own without some kind of medical intervention and successfully withdraw and become sober is slim and none, and slim's out of town. You know, if you just if they're just out there in the world. I'll try. I'll go to the house and, you know, try not to drink anything, try not to smoke anything, try not to shoot anything, whatever. But when, you know, I'm tweaking, and when I'm getting sick, I'm getting sick. And those are powerful negative reinforcers for me to go back and use. Some withdrawals are dangerous. Withdrawal from central nervous system depressants, including alcohol. Alcohol is a very dangerous drug for an acute alcoholic to withdraw from because the withdrawal syndromes can kill them. So if you have acute withdrawal, then you should, if at all possible, refer the client to a medical detoxification unit where they can be basically watched by medical professionals who can help them come down. Then there are biomedical conditions and complications that may complicate treatment, including emotional behavioral conditions too. People who are having psychotic episodes, they're not, here in reality, or they have some other illness going on that requires treatment before we can, so that we can stabilize them physically and mentally, and they can, appreciate treatment, can really participate in it and get better. Acceptance of the need for treatment. That is not something that is universal. Often there are, people just don't believe in it. There are cultural prejudices against people going into treatment, or cultural prejudices against people who do go into treatment, so it's not always accepted. Relapse, or the likelihood of continued use, that's another reason you might want to consider when you're deciding which treatment setting you want to put someone in. And then the recovery environment. It's hard to sober up in your bedroom by yourself when your roommates are partying in the living room. And yes, I've done some field research on that. Assessment of placement dimensions inform choices levels of treatment. If there's if the placement dimensions are low, level 0.5, early intervention education is what you'd bring to bear on it. As it moves up to level 1, then you might consider just outpatient services. And then as the intensity of the symptomologies of the problems increase, intensive outpatient, inpatient residential services, or medically managed intensive inpatient services. We also have another group that are tricky when working with them, and this is the treatment-wise. These are the veterans of the war on drugs. They've been in and out of outpatient, intensive outpatient, inpatient self-help programs over the years, and they present a unique challenge to the treatment provider. They speak our language, for one thing. They know how to say the kind of things that a counselor might want to hear. And the client's progress or lack of progress in previous treatment efforts need to be carefully evaluated to see, what they did, how they did, that sort of thing. It may be that more intensive treatment is necessary. If you have someone who's just going to 12-step support groups and doing the AA 4-step 1, 2, 3 slip, 1, 2, 3 slip, 1, 2, 3 slip, then something more intensive may be called for. Their lack of success is not necessarily tied into their levels of motivation, by the way. They may very well be motivated people, but for some reason they just can't get through this impasse that they seem to have encountered. They shouldn't be considered failures if they keep coming back, by the way. If they keep coming back, they keep coming back, and that means they're working towards something, or at least trying, huh? And relapse isn't uncommon. It's not an everyday thing. It shouldn't be just ho-hummed, but is not something to necessarily get bent way out of shape about, because it's a possibility for everyone. Yeah, well, how many times should I work with them? 70 times 7 or so? I heard that was a good number somewhere. I don't know. I'm glad that there was no maximum limit on desired chips that people could pick up in AA or NA, because honest, if I fell in the bay with all of my chips in my pocket at one time, I'd have gone down like an anchor. So I was a relapsing son of a gun for about 3 years there, and so I'm glad that they didn't set that limit. I had no idea my last desired chip would be my last. All those others hadn't worked. Anyway, when you come into treatment, there's a number of things that can happen when you're seeking to change what you're doing. One of them's harm reduction. Someone called this compassionate pragmatism. I like that. And the recognition that some people are not seeking, nor will they accept, total abstinence. That's not part of their goal. That's not what they want out of this. That's not part of the deal for them, at least not initially. I don't know if this is still going on right now, but the Search Project in Houston had an apartment complex where they could get people who were homeless and had substance use disorders and things like that. They had programs to put them into apartment units inside this housing complex. And what was surprising to me initially was that sobriety was not a requirement. You could still be getting high and get a place to live in there, even though it's a recovering community. Now, I'm thinking, well, if you put these guys in there, it's like watching an episode of The Walking Dead. If you let the wrong person in, next thing you know, that whole relapse thing is going to be like spreading from person to person, and they're like a zombie bite at Woodbury. But that didn't happen. There were some, of course. What was more likely to happen is that the person who was using, who came into the recovering community, reduced their use and sometimes totally stopped their use, because it wasn't because anyone was proselytizing to them or preaching to them. They just did, and they began to fit in with the rest of the community. Harm reduction rejects negative labels with the addicts, dope fiends, all of that stuff. Treatment failures. Harm reduction engages clients. It starts where the client is, where they are right now. If wherever you are is fine. Whatever motivation you have is fine. It doesn't require abstinence. What I do require is that we have a collaborative relationship, that you level with me, we work back and forth. I want to use your strength to foster change. Recognize that substance use exists on a continuum. We're all on it somewhere, and it redefines what we consider success. And now, when you're getting into treatment and treatment objectives and treatment outcomes, definitions of success becomes important, does it not? Difference between alcohol incidence and alcohol use disorders and treatment. Alcohol incidents are present when negative consequences result from an individual's drinking. An injury, a DWI, fight, leading to police involvement, any of that stuff. However, a clinical evaluation indicates no pattern of recurring problems to indicate abuse or dependence with the individual. Then you're having alcohol incidents. And that doesn't necessarily make you an alcoholic or give you a chemical dependency problem or a substance use disorder, so to speak. But it does give you a problem. Alcohol use disorders is chronicity. This is where it happens all the time, where it's not isolated incidences, where it's not every once in a while. It's pretty much on a regular basis that you're experiencing these consequences from your use. And that's what we look for diagnostically. I'm not looking for a person who's had one blackout or one DWI or, lost one job or, any of that. Although all of that can be catastrophic for certain individuals. It can just be terrible. Uh, but what I'm looking for is patterns, and patterns indicate that chronicity, and patterns are where I'll, be looking to insert, to bring about interventions to interrupt these specific patterns that we've identified. So that becomes very key in the evaluative process. There are obstacles to treatment, of course. There are cultural prejudices, which I mentioned a while ago. Uh, Finances are always a concern. I'd like to go, but I can't afford it. Well, we can get you in free, but no, you don't understand. If I go in, my boss will fire me, and then I can't feed my family, and I can't pay my rent. My car will get repoed. Finances are an issue. Client resistance. I don't want to. I don't want to do this. This is not something that appeals to me. I think I can handle it on my own. In fact, I know I can, etc. Lack of treatment resources, not just not having money to pay for it or not having insurance, but having no place to go. There are areas in the United States of America, man, where you better not get sick with any of this stuff because there is no place for you to go. There is no hospital, there is no treatment center, there are no outpatient clinics, there's nothing. Uh, Co-occurring disorders. This can be a real problem in treatment and trying to get compliance either with your psychiatric regimen of treatment or with your substance use disorder regimen of treatment. And then there's uh, uh, and then there's lack of belief or faith in treatment. I just don't think it works. I mean, I've talked to a lot of people; it doesn't work. And I went to those AA meetings, and that just made me want to drink more. I mean, when they sit there and talk about, all this drinking and stuff, I just want to drink. Successful treatment, how we'll define it, addresses dysfunctional life patterns that are not always immediately evident. And if they are immediately evident, then you address them immediately. But some people are able to cover up things better than others. And over time and working with clients, you constantly review your treatment plans. You should have your treatment plans reviewed on a regular basis anyway, to see if the client's, completing the tasks that you've set collaboratively, if he or she's attaining the goals that you decided were important, and all of that good stuff. Psychological wounds comes with the territory, and you might as well get comfortable with that because it can be something that is devastating, for people, and it will come boiling up. And they've been using drugs to hold these as a way to manage these psychological wounds. Physical issues, a toll is taken on the body. I mean, when someone says in a meeting, hi, I'm Howard, I've been clean and sober for 9 months, I know what they're saying, but if they've been using drugs for 15 years and they've been 9 months sober, they are hardly clean and sober. Their body hasn't rebounded. To the extent that it's going to rebound, it may not get 100% better. There are some things that our use does to us we don't really ever recover from, but it will bounce back to the extent that we can bounce back from it. And so if you spent the last 15 years, drinking with both fists and popping pills and things like that, it's probably going to take you 18 months to 2 years, 2.5 years before you can really say, I'm clean and sober. My body is, recovered. I'm back where I should be. Deterioration in family function and relationships also comes with the territory. And that's pretty clear, pretty evident initially. This may be something that brings them into treatment, and it shouldn't be negated. what the client wants is important. If the client is there to save their marriage, that's a damn good reason to be in treatment, and you shouldn't be convincing them that they shouldn't have that as a goal. Oh, well, that's fine, but you need to concentrate on yourself and getting sober. Now, if you're here to save your marriage, that's a wonderful reason to be here. If you're here to stay out of jail, that's a groovy reason to be here. If you're here to keep your job, that's a spectabulous reason for being here, and I will applaud that all day long. What the client wants is important, but at the same time, what the clinician wants is important too, given the fact that we're identifying a substance use disorder and certain dysfunctions and certain incongruencies in their lives, and we're going to advance some methodologies for clearing those up. Their best thinking got them here. I'll never forget my friend and mentor Spencer Andrews telling me that when we were having a discussion about how much the client should direct their treatment one day, and he said, "Remember that, Ben, their best thinking got them here. Their best thinking brought them right down here to Center Street, to DAAC, to a drug program. That's what their best thinking got them. That's what they wanted got them." And I agree with that. There's a lot of truth in that. But that doesn't mean that their desires are all warped, and that doesn't mean that everything they choose is wrong, and that doesn't mean that they don't have the right to choose what they want to choose in their lives. Often we're putting out fires, and these are issues that are of significance to the client. These are burning issues for them. They may not be for us. They may not even seem significant to us. Once upon a time, I watched this disaster movie where people are coming up out of a subway tunnel where the world's been blown up above them and they have to struggle to get out. And Valerie Harper was in it, and some other characters. But Valerie Harper was the one who, she was like comic relief. Everybody's doing this, having these disasters, and she talks about her cat. His name's Zorro, and she said because he left his mark all over the apartment, so Mark of Zorro. I hope Zorro isn't alone. I hope he isn't afraid. I hope that the electricity's on because he really doesn't like to be alone in the dark. And I hope he's got enough food out. And I hope he can get to his water. Till one of the characters finally goes off on her and he said, "Will you shut up about the damn cat?" He said, we don't know we don't know if we're going to get out of this tunnel. We don't know what's up top. We don't know. The world could be gone. The world is gone for all we know. All you can go on about is that damn cat. What's so special about that damn cat? And to which Valerie Harper replied, "He's all I've got," And that spins it. The crisis, that's small potatoes to you and me is the whole damn farm to somebody else. And we have to be cognizant of that. So what the client wants and what the client deems is important. And we shouldn't let that slide out of our field of vision. They're going to need help with skills of daily living. And some of us don't even know how off the chart we are with the way we live our lives, We've normalized some really weird ways of interacting with the world and need to develop skills to combat that. Also, acknowledge the client's accomplishments, every stinking one of them. When they do something, it doesn't cost me anything to admire somebody for what they've done or what they're doing. And it may be invaluable to the person who gets the admiration. Treatment issues, adjusting memories. Oh, what do you mean adjusting memories? Memories, I mean, you remember stuff that either happened or it didn't happen, right? No. Memories are very creative. And the way we remember things are through our own lenses, through our own context. And when we're interacting with family members, we may discover that our memories aren't their memories, even though we experienced the same thing. So adjusting memories becomes important. Dealing with emotional extremes, and we walk in with plenty of them. This is some of the stuff that we medicate. Uh, you know, I try to deny stuff. I try to deny that things are as bad as they are. I try to deny that they exist at all. I deny that I have any problems. I deny that I need any help. And that's a defense, an ego defense versus anxiety. I'm either feeling guilty for all the rotten stuff I did because I'm such a rotten person, except you made me do it, damn you. If you hadn't have done this, I wouldn't have done that, etc. So I'm swinging between those two extremes. Yeah, I'm here to get well. I'll do whatever you want me to, but that, I will never do that. Don't you even ask me to do that. In fact, I don't think I want to be here anymore. To hell with you people. Uh, yeah, and all of that in one session. Repression versus being overwhelmed emotionally. Uh, we repress things to not feel them, to not be aware of them, to not allow them in our consciousness, to not act on them, etc. And what if I give myself permission to feel all these feelings you think I ought to feel, and then I can't stuff them back in the box? Then where will I be? Then how will I be? What will be? Relationship, dependence, and intimacy. Oh my God. Uh, there's been tons of literature written about recovering people and relationships, sobriety, and relationships. And not to say that our relationships are good when we roll up into the program. Uh, Maybe you can relate to one of these pictures. There's clingy people and there's not so clingy people, people who are distancing you, pushing you away, arguing with you. The, uh, uh, the idea that someone's got to win in a relationship, the power struggles, or the togetherness that suddenly one day becomes too much. Uh, the person who won't let go no matter what. This guy may be a stalker or worse uh, down there, but uh, it's been my experience in recovery, and 12-step recovery particularly, where I spent a lot of time in groups with people, with individuals. I watch relationships come and go, and my own too, for that matter. Uh, I decided one time that if you scratch a substance use disordered person, you're going to find someone with an intimacy disorder underneath it, with attachment disorders underneath it, stuff like that. Uh, we don't necessarily get into relationships, we take hostages. I was thinking about that. I forget which Harry Potter movie it is, but he reminds me of Ron when the witch put the love potion on him, and she was just like that. He couldn't get away from her, and for a while he liked it, but then the potion wore off. Uh, but you know, we're like amoebas. We just roll over people and absorb them, and that's an intimacy disorder, or not letting people be close, pushing them away before they push us away, and misunderstanding what intimacy is, and misunderstanding how relationships work. Then there are the big whys. Why am I like this? Why me? Why did that happen to me? How could this happen to me? What happened? What was it? How, da 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 da. If I tell you why, and I can tell you why something happened to you, does it make that thing that happened to you go away? Does it lessen the anguish that you feel because this thing happened to you? Uh, it, why me? Why not you? Who's exempt in life? Uh, Why? Why do I? I don't know. Those are questions that you should ask yourself at some point. But don't expect them to be the solutions to your life. Turning the why into what do I do differently? How do I get out of this? How do I change that? What do I do to make this go away? Now you're talking. Now you're talking how to make this different. Uh, and the truth of the matter is, I feel a great deal of sympathy for people who are going through this. When I looked at this, I was looking for some images to post up here, and I thought of a lady I haven't thought of in many years. She was in my DAAC groups back in the late 80s, but she was uh, a fine, upstanding lady. I mean, she was, active in her PTA, and she was a soccer mom, and she did all this wonderful stuff with kids, and she was active in her community, and she got a DWI. And why? How did that happen? How could they do that to me? And even the cop who carried me in knew who I was, and still he treated me like a damn criminal. Why did he treat me like a criminal? And the obvious answer, of course, is because you had just committed a DWI, you are a criminal. But I didn't belabor that. Uh, if you know why your father was mean to you, why your mother abandoned you, why your boss fired you instead of that other uh, rotten person who did half as much work as you did, or why the police picked you out of all of the people at Mardi Gras to arrest. Why? And you know the answer to that, it doesn't change anything. Our job is to move people into a way of thinking that's transformational, where they can change things, right? Relapse. It's always a concern. And there's no way to cut it where relapse is not a semi-expected and normal, or not necessarily normal, but it's a part of recovery. As I said earlier, I relapsed a lot, but I lived. Relapse is fairly common. Anyone who has a chronic illness is subject to have a return to active symptoms, a flare-up, a relapse, if you will. Relapse is fairly common in the treatment field. It's not inevitable, but it's not necessarily the end of the world. And actually, we can use relapse to formulate a more robust type of relapse prevention program or relapse prevention initiative with our clients, because we can recognize you know, where things went wrong. But relapse can also be the end of it. As I was putting this together, I thought of a guy in Baytown about 10 years or so ago who was working as a counselor who had a relapse. He got fired from his job because you can't have a loaded counselor working with your substance abuse patients. And he was offered treatment, which I thought was very kind of the agency that they offered to put him in through treatment. But he refused all that, and he left, and he went straight to the Hartman Bridge and jumped off of it, and that was that. And that's another way that people die in this illness. And there were a lot of things going on. A lot of things went wrong. And that was the inevitable, that was the not inevitable, but nevertheless ending to the story. It wasn't necessarily the inevitable. So relapses can always be life-threatening. Relapse prevention is indicated prevention. I know I shouldn't have put that. That's not as tertiary prevention, as after an intervention has taken place. It's also indicated because a person's used before. It should be part of any treatment effort. anytime that you provide treatment to someone, you have to take into consideration that they may relapse, and it's a good idea to have some kind of plans in place for them should that occur. Treatment outcomes are not as simple as successful and unsuccessful, although we talk about them that way. We talk about treatment successes and treatment failures. That's not a good way to talk about people. And that's what you're talking about. You're talking about individuals whose treatment outcome was positive or whose treatment outcome was a return to use. But if we're going to talk about treatment outcome and we're going to talk about success and unsuccess, by what measure are we going to talk about it? If treatment doesn't work, is all lost? I mean, is it all over for everyone? If you stay sober 5 years and then relapse, does that 5 years not count for anything? Is recovery not using anything ever? Or smoking pot occasionally? Or not using for 1 year? Or 5 years? Or 10 years? Or forever? Anyways, you can see it can be awfully subjective. If you're in AA and you relapse and you got this 3-month chip, and I know because I did the field research, you go back to the desire chip and start working again toward that blood chip, which is 30 days, the red one, and start all over again. You got a new sobriety date. I don't remember what all my original sobriety dates were, but I remember my first time I ever picked up a desire chip was the same week that Iran overran the American embassy in Tehran and took the hostages in 1979, November of. And that didn't take. And the last one that I picked up was on April 20th, 1982, which was the last desire chip I ever picked up. It still seems to be working. It's also Hitler's birthday. I didn't plan that. It just turned out that way. And it's the day after Patriots Day and Ruby Ridge and the Murrah Building bombing. And there's a whole bunch of, I don't want to be anywhere near a federal building in the week of my sobriety birthday because it can be crazy. But anyway. Factors influencing outcomes, by no means comprehensive. I know where I was going with that. Was I a sobriety failure every time that I blew it and had to, go back out for some more field research? Or was I a winner because I kept coming back? I kept trying. I kept picking up chips, whether they worked or whether they didn't. I kept going and trying to do stuff. I would go to NA meetings and continue to drink because drugs were the problem, or I would go to AA meetings and continue to smoke weed and do coke because alcohol was the problem, And sometimes I go loaded, and I'm glad they didn't, make me go away just because I was intoxicated. And they didn't. They just told me, sit down, shut up. And I did. So, am I a treatment failure or a treatment success? I don't know if lifetime sobriety, I can't really consider myself a success, just a success so far. Anyway. Factors that influence outcomes, and this is by no means comprehensive, and this can be both positive and negative. Client's evaluation of counselor competence. If we think that our counselor's working for us and knows what they're doing, then we respond positively. Therapeutic alliance, the relationship between the counselor and the client. And I can't stress this enough. There's been a number of studies that say this is the key. If you and your client trust one another, agree to work with one another, do and live up to the commitments that you make to one another, you'll get better. Length of contact. For a while we thought long term, absolutely long term. But it doesn't have to be long term treatment to make positive differences in a person's life. Are positive differences, changes that people make, even if they're not staying sober, even if they're not completing long-term treatment. Is that a good treatment outcome? Is that a positive one? Length of contact, duration of treatment, kind of the same thing, how long I keep you in. Counselors' emotional responses, how I respond to you emotionally. We are key at reading one another's emotions and responding based on that knowledge. Counselors' interpersonal style, the things that the way that I interact with you, how I counsel, and how I respond. And adherence to standardized approaches, and that's kind of gives my counseling focus. If I'm all over the place, grabbing some of this and some of that, and doing some of this and abandoning that and doing something else, I'm probably not going to get a lot of places with my clients. But if I have an approach that I'm comfortable with, and I am adhering to conventional best practices, then we're probably going to be pretty good. Iatrogenesis, and that's where something that the clinician does that causes an illness or causes an illness to worsen. And that's really not much of a problem in addiction counseling, but it's not out of the realm of possibility. When you're talking about iatrogenesis, you're usually talking about results from use of medications. You have a bad response to the medication, a disease results from that. In our line of work, iatrogenesis may result from consequences for ethical transgressions. We can do harm to people by dual relationships, becoming, getting sexually involved with someone or borrowing money or whatever. Or using techniques or interventions that we're not well versed in, that we're not truly competent in, or that may be inappropriate, and that can bring unintentional harm to clients. And it's still harm to clients, even if it's unintentional. Well, that's something we should also be aware of. So, and you thought I'd never get to this point, didn't you? In conclusion, substance use disorders are multivariate syndromes which can be treated a number of ways, and they are treated a number of ways. Not all problems with substances can be considered disordered, but they are problems, and people can use our help to resolve those problems. And it may just be through education or suggestions. We can and should be of service to those who are not diagnosable but still experiencing some type of substance-related disorder if we insist that people have to be diagnosable in order for us to interact with them or to provide services to them. Then we're going to miss a lot of people, and some of whom will return when their conditions worsen and we can diagnose them, etc., and so forth. Another true confession time for me. When I was first involved with Palmer Drug Abuse Program, I saw all these little kids, man. I mean, 13, 14, 15-year-olds who, got caught with weed at school or something, and mom's dragging them in by the ears. And I'm like, dude, at that time I didn't really consider weed a drug or a problem or anything. And and these little guys would come in together all in a group, and they would get sober together, and they would hang together, and then they would go out together, and they would relapse together, and we wouldn't see them for a while or for long times. And I thought, boy, what a waste! No one's getting sober, and this is just a waste of everybody's time. And you know what? Once again, I was wrong. Because I began to see these people popping up in the recovering community. These kids had been dragged in when they were 13 and 14 years old. And now they're showing up in AA meetings and NA meetings and, all across Texas. I even ran across one in Wyoming. Who they were dragged in as teenagers and they went out and relapsed. But you know what happened was as they got into heavier use, as they got into more trouble, as they recognized it earlier, and they knew there was a solution, and they came in on their own. They began showing up in recovery groups in their early 20s, not in their mid 30s or early 40s, you know. So there's a whole big chunk of years there of suffering that these youngsters were saved. Treatment is effective, and this is something that I don't believe that our profession is very good at getting out to the world. What we do is worthwhile. What we do matters. What we do promotes recovery for individuals, and our treatment methods work. Oh, okay. I'm off my soapbox. You thought I'd never do that either, did you? Yeah, no. There you go. Uh, there you are. So that's that. I hope you had a good experience this semester. Don't forget to do your course evaluation because that's important for us. Use the rest of the time that we have after you finish this to complete any work that you may be missing. And I look forward to seeing you again. I look forward to you seeing me again in the near future. So have a good Christmas break. Merry Christmas. See you soon.